So thank you for the invitation. So I will present a way that we use in Bordeaux to start with NAVA and a way to adapt NAVA level. So I work in a thoracic ICU with lots of surgical patients and lung transplant patients. So first of all, as it was a topic yesterday, why do I use NAVA? It's because we have serious COPD who have surgery for emphysema. We have patients with cystic fibrosis and lung transplantation. We have patients with large bronchopulmonary fistula and large leakage. So in this situation, we had a great improvement of the treatment of the patient with failure of pressure support ventilation. That once we were convinced that it could be helpful in our department, we had to choose the population in which we wanted to use NAVA, and we chose to use it initially during the weaning process of ventilation, which means that the idea was to adapt the work of breath, the drive. Most of the patients were intubated. They were all intubated, so it was easy to put the nasogastric probe, NAVA probe. And the idea was to go from volume control ventilation to a single breath trial. And the way we do it is using pressure support ventilation with 7 centimeters of water and no PEEP. But you can use other way, depends on what you are using to do a G-tube or a CPAP-5. So our way is PSV 70. So there's an interesting review of lessons from weaning failure, and I read this article with lots of interest. And finally, even during pressure support, it's not obvious to have the optimal pressure support when we choose it at the bedside. And it could be to adapt the tidal volume, to adapt the respiratory frequency, or the transdiaphragmatic pressure, which means that you have a balloon in the esophagus. So it's invasive way to have this data. So will I start with NAVA preview? The idea was when I start with NAVA is finally if I want to climb the stairs, how many balloons do I need? Balloons, and have to deal between under and over assistance. So much of the time you start from volume control ventilation. The probe is supposed to be in the right place. You don't have any signal. So you hope it's in the right place, but you don't know, probably because there is no activity because you're under volume control ventilation. And then you start with pressure support because you think it's a good time for the patient. And what you see sometimes is a very poor electrical activity. And finally, for us, when we start with NAVA, what we observe most of the time is that the EAdi during pressure support ventilation at day 1 was quite low. So that's our way to do it. We test every day if the patient is able to breathe by himself with a very low assistance. And you can see the difference in terms of EAdi. And probably, if you start with NAVA looking at this patient, you will not start with adapted NAVA level. So we don't use NAVA preview for that. And we think that there is lots of information with the EAdi between those two opposite ventilation. So NAVA preview for us is a good tool. It's helpful if you want to improve pressure support ventilation and to improve synchrony using the cycle and the PEEP. It's a good tool to see spontaneous breathing during RPRV or whatever. It's a good tool to see different tidal volume and explain this by the spontaneous breathing. It's also a good tool to see reverse triggering as shown yesterday. So electrical activity of the diaphragm during pressure support ventilation, we know that when you increase the pressure or when you decrease the pressure, then you have an opposite action on the diaphragmatic activity. Once you increase pressure support, you decrease diaphragmatic activity and you decrease transdiaphragmatic pressure. So finally, we have to deal, this is in healthy subject, but it's high versus low level. And probably it depends on what kind of pressure you are dealing with. And probably during the weaning, we want to still have negative esophageal pressure. We want the patient to have some work of breath. And you want to test this ability to breathe like this every day. So this is what you have seen today and yesterday, finding the right NAVA level with a tidal volume titration. So this is an example. And what is interesting is that when you are in the adapted NAVA level, you have this plateau of tidal volume, which is quite quite large. And what we think is you have, during this plateau of tidal volume, a difference in transpulmonary, in pressure time produced and in EAdi. So probably, once you start with NAVA low, you also have the EAdi during a low pressure support, which is your baseline, so 100%. And this information could be very helpful in finding the adapted NAVA level for your patient when you start with NAVA during the weaning process after a long time, after mechanical ventilation. So the first question was, what is normal EAdi? And my answer is, I really don't know. My experience during the weaning is still that I don't know. But what I know is what is an abnormal EAdi, which is finally the EAdi we have when the patient is unwell. So if you test every day the ability for the patient to breathe by himself, and then he failed the trial and you have the EAdi, maybe it's a good start to give some sense to what means this EAdi for one patient. So the adapted EAdi will be an electrical activity that is less important than the one you can see when the patient is unwell. So there's many studies who have tried to adapt exercises, muscle performance with electromyogram, surface electromyogram, but they were adapting the effort to the maximal effort and reducing the effort from 50%, 40%, it depends on what you want to do during the training. So our design was to use the same kind, that's the way we do the trial every day. We try to see every day if the patient is able to breathe with PSV 7.0, and if it's not the case, it goes back to pressure support ventilation. So we adapted this in a way to use NAVA, and so after more than 4 days of mechanical ventilation, most of the patient was after IODS and respiratory failure. We use 1 hour PSV to see if the patient is able to breathe spontaneously. So it's a screening. And then if it's possible, we try the SBT. Most of the time at day 1, it's not possible. And then we record the data during the SBT. If he's able to spend more than 2 hours with the SBT, then we propose the extubation. Otherwise, we start with NAVA, and we adapted the NAVA level to what we recorded during the SBT. And we did that every day until extubation. So this is a video of, I hope we'll see something. So this is a patient under pressure support ventilation. I will reduce the level of pressure support. So it was 16 and 6 centimeters or whatever of PEEP. So I reduce everything. You can see that the signal is not very clean. And when you do that with 7 centimeters of pressure and no PEEP, you have this increase of the EAdi who comes very soon. And you see that the patient is increasing his respiratory frequency, the tidal volume is too low. He's not able to do a spontaneous breathing. So after 1 minute, we stop and we put the patient with NAVA. And the idea was to reduce the drive of 40%. So we start with NAVA. It's another NAVA titration. You have to find the right NAVA level to have the drive that you wanted. During pressure support with 7 centimeters of water, we had 8 of EAdi, around 8, and in this case, we'll try to stay around 4 or 5 microvolts. So after 1 hour, the patient is breathing quietly, and the drive is adapted to his demand. So if you look at every cycle during the SBT compared to pressure support ventilation, well, we see that the level in pressure support in EAdi was low, and during the SBT it was high. You have sometimes value like this that you want, so your maximal EAdi that you will take into account during the SBT won't be this value, but the mean during the SBT. And after that, then you settle NAVA in order to reduce the drive and do a certain percentage. We have chosen 40%, but that's our choice. It can be discussed. So the more important thing is once you unload the patient like this, so that's in NAVA, and we do the test. It's day 2 or day 3, and we have an increase of the drive during the test. Sometimes it comes very soon. Each bar is 1 minute, and that's the mean. So when you look at this, what we want every day during the weaning process, finally, is to see a step like this until the patient is able to be extubated. So this is two different kind of trends we can have, but you have to come back to see the trends to be sure that the drive is not too high or too low, and to adapt again your NAVA level if you want to, if it's not in the right settings at the beginning of the new level setup. So what we had is that effectively the pressure support has a lower EDI than according with our protocol. And when we were doing the SBT at day 1, the maximal SBT was 16. So we're quite far from what we had under pressure support, was adapted according to the tidal volume. So probably when we have tested 7.0 at day 1, it was too low, but it gives us this information. And when we look at the pressure support ventilation at day 1, it's very flat. And finally, during the weaning process, it's definitely something that we don't want. So it makes sense to rapidly change these settings on pressure support. It can be on pressure support once you have the EDI to change the level of pressure, because in this case, without EDI, it thinks that the patient is very well ventilated, nice volume, tidal volume, nice frequency, nice arterial blood gases. But finally, is triggering the ventilator most of the time, and is not doing sufficient effort, and that's not what we want during the weaning. So if we compare day 1 and the extubation day, you have a difference in EDI maximal during the SBT. It's increasing. You have a difference in the NAVA level. We were allowed to reduce the NAVA level during the weaning process. The patient maintained his tidal volume. We reduced the pressure support, and the respiratory frequency is not very different, so it's not very helpful. What was interesting is during D1 and day 3, we had an increase of the EDI maximal. So it's interesting because it's every day at the same level of pressure. So you're comparing, the comparison is with 7 centimeters of pressure, and it increased for almost all the patients. So to question, maybe ventilator-induced diaphragmatic dysfunction, or probably more residual sedation after a long time mechanical ventilation. So this was discussed earlier. I think it's too soon in 3 days to see reverse of the atrophia that could have been done by mechanical ventilation. So most of the time, if you reverse the sedation using, for example, a patient who was under midazolam, and then you use flumazenil to antagonize the sedation. We did that under pressure support because we wanted to see, first of all, the increase of electrical activity, but also that the tidal volume is increasing. So it's not only the drive, but also the efficiency in terms of volume that has changed. So probably between the first 3 days, the increase in EDI and during the weaning process is a consequence of the reduction of the effect of sedation, which finally is not a problem as we adapt the way we use NAVA and the level of NAVA and our NAVA level to the increase of EDI during the SBT. Another example of finally of a reduction of EDI when you use non-invasive ventilation after extubation. That's another way to have your EDI during the spontaneous breathing, and then you use NIV and you see a reduction. You can imagine that the more, if the patient is very sick or if we want to unload it a bit more, then you will try to have a higher decrease during the NIV ventilation. So you can target your NAVA level to the EDI you had during the respiratory, the spontaneous breathing before you put the patient under NIV. So it's a simple observation, and you are able to see at the end of the day how many times it was on NIV and how was the drive during this non-invasive ventilation. So this was discussed just the last talk. Effectively, when you look at patient, so this ratio at day 1 when the SBT is not successful, you have a reduction during the SBT of the the neuroefficiency, which is because you have to increase the load. And when you look at the day of the first day of successful SBT, then you still have a reduction, but there's a difference. The reduction is significantly different. But the day of extubation, you still have a decrease of this index between NAVA and the SBT. So I think you still have to use something with the same level of pressure. It could be CPAP or pressure support ventilation with 7 centimeters of water, which is what we do in France, or a T trial. Everything is possible. And if you look during the SBT, when it was unsuccessful, and if you compare when it was successful, it doesn't work just because tidal volume has increased and EAdi has also increased. So during the weaning, it's a bit different what we could have attempt from this index, just because EAdi is increasing, probably because of sedation or things like that. So I think that titration of NAVA is, we have to do it. It could be using tidal volume or EAdi. When we use EAdi, we have to give some sense to this electrical activity, and finally having the value of the EAdi with the lowest pressure support, or here it's a recent paper of the Italian group with 0.5 NAVA, gives you many information and gives you a clinical sense. Then you know what means the EAdi you have on the screen for this patient. So daily measurement of EAdi and tidal volume could be interesting, as it could be correlated with patient's recovery. But finally, what you will do is you will test the SBT every day, and if the patient is passing the test, then you propose him for extubation. So I don't think it will change your mind if the patient is able to do the SBT. Whatever the drive is, you will do it. And that's it.